follow-up post-biopsy. In fact, honestly, the last year I can't remember that we have done it. It's very rare. If the radiology pathology results are malignant and congruent, we make 2 appointments. Now, please remember the way we work in my practice, and I think this is good patient care. We have taken a process that in the United States would normally take 3 to 4 weeks, and we often accomplish it in a week. Patient has a screening mammogram, we call her back. She has additional views, we think it's a cancer, we do a biopsy. She's back within 24 hours for results. And then the surgeons have agreed to see patients with a cancer diagnosis within 48 hours. Again, we don't want our patients out there worrying that they have a cancer and it's not being treated. So screening mammogram, additional views, biopsy, surgeon within 48 hours. So when she comes back for her biopsy results, I will make an appointment with her to see one of the surgeons, and I make an MRI appointment before they see the surgeon. So that by the time they see the surgeon will have the MRI results. And now we can talk about conservative treatment, we can talk about neoadjuvant therapy in the right scenario, we could talk about mastectomy in the women that have multicentric disease on MRI. Excisional biopsy for the high-risk lesions, this includes atypical ductal hyperplasia. Here again, please talk to your pathologist, know what they call atypical ductal hyperplasia. Yesterday, I was asked a question about papillomatosis with respect to multiple peripheral papillomas. You need to understand the terms the pathologists use. Some pathologists will use papillomatosis to talk about hyperplasia. Some pathologists will use papillomatosis to talk about multiple peripheral papillomas where there is a central fibrovascular core. Hyperplasia doesn't have a fibrovascular core. And now some will use that term interchangeably. We need to know, am I dealing with hyperplasia or am I dealing with papillomas? Because I'm going to follow my papilloma patients a little bit more carefully. So know your pathologist, know when they call atypical ductal hyperplasia. If there's a question pathologically about a fibroadenoma versus phylloides, we're going to recommend excision. With some papillary lesions, and what do I mean by this? The larger the papilloma, the more I have to worry about a sampling bias. The older the patient, the more I have to worry about papillary carcinoma. So in larger lesions, older patients, if I get back some kind of a papillary diagnosis, I'm going to generally recommend excisional biopsy. And lobular neoplasia, or lobular carcinoma in situ, very controversial in the United States. There are some facilities that always recommend excision, and then places like me, I hardly ever recommend excisional biopsy for LCIS. LCIS is an incidental finding, and I don't usually recommend excisional biopsy. But there are lots of places that do. And then complex sclerosing lesions or radial scars are entities that I excise. In my patient material, about 33% of my patients with complex sclerosing lesion, when you take the whole thing out, you find tubular carcinomas, you find low-grade DCIS, you often will find multiple papillomas associated with these. So it is some type of proliferative process that has a high association with some of the lower-grade invasive lesions.